Dave Morrow. I'm the section head of critical care cardiology at Brigham Women's Hospital and a professor of medicine at Harvard Medical School.
I'm Bram Geller. I'm a critical care cardiologist at Maine Medical Center. I'm assistant professor of medicine at Tufts Medical School. I'm the director of the cardiac intensive care unit at Maine Medical Center and also serve as the director of the temporary mechanical circulatory support program.
In terms of safety checklists in the ICU and what principles that should be really driving what we do around safety in the cardiac ICU.
I think some of this stems from a previous scientific statement led by Dr. Fordyce that was an American Heart Association statement published in 2020 about preventing complications in the CICU, because a lot of the therapies that we use in the CICU, whether it's mechanical circulatory support, inotropes, ventilation, CVVH, all those things are beneficial for our patients, but carry with them their own risks. And I think to really optimize and achieve the best outcomes in level one CICUs, but really all CICUs that take care of complex cardiac patients, we need to be mindful about how we mitigate these complications, look out for them, address them, and make sure that we can use checklists and dashboards to make sure that we're kind of using all the principles that we know and applying them to each patient every day, because we know patients in the CICU are incredibly dynamic and things change on a day-to-day basis, and it's very easy to miss some of these checklist type items. But we know from robust data in medical ICUs and other ICUs that if we're able to maintain a lot of these checklist items, that it optimizes outcomes and improves patient mortalities in the CICU.
Yeah, I think it's worth emphasizing that point, and that much of what we tackle in the scientific statement is based on the expert integrated experience of a broad interdisciplinary author group. And in some ways, much of it is forward-looking based on our experience. But this is one of the areas where we have the strongest data set from across the spectrum of ICUs to know that we can improve outcomes with these specific safety measures that fall under the A, B, C, D, E, F categories that have been used in general ICUs. And then I think the other area that has really progressed from 2012 is that the data that drove us toward high intensity staffing models in general ICUs, we now also have data in cardiac intensive care units, which we did not have when we wrote our statement in 2012.